のディレクターもお務めで、いろんな養殖もされていて、で専門白内障はもういろいろされて、フェムトセカンドをされたりとかですね、それからもちろんレーシック系のリフラクティブもされているということであります。で今日は、ですね、ポステポーラーカタラクトとか、あとは、水白内障の話もあるかなと思うんですが、いろいろちょっとその、難しそうな白内障の実際の映像をたくさん見せていただけるんだと思います。Okay, Dr. Lim, please go ahead your lecture.
Thanks, Dr. Oshika's invitation, and also thanks Hoya Company's arrangement. Good afternoon, ladies and gentlemen. I'm Dr. Brian Lin from Taiwan Universal Eye Center. My great pleasure to share with you my topic today. The first topic is how to manage posterior polar cataract. Posterior polar cataract is a round discoid opaque mass located in the central posterior part of the lens, which can always obscure the visual axis. Clinical presentation reveal 11% to 36% PC rupture in posterior polar cataract surgery. We can see the anterior lens epithelium is simple cupoid epithelium. However, posterior lens epithelium is always absent. Any lens epithelium cells between here are always a pathologic change. The lens capsule is a modified basement membrane that completely surrounds the ocular lens. The thinnest part is near the posterior pore, around 2 to 4 micrometer. The pathogenesis of posterior polar cataract is still a mystery. However, most of the published consider it clinically and histologically appears similar to acquired PSC. However, there are some congenital type, which we can see fishtail sign here. In all probability, the subcapsular posterior cortex cell degenerates earlier. Later, the lens epithelium cell proliferates and migrates posteriorly, frequently reaching the posterior pore of the lens. The abnormally positioned epithelial cells enlarge in a grossly aberrant manner and produce large beasley-shaped cell, named the widow or bladder cell, constituting a PSC or polar cataract. I consider this is why the posterior capsule here always thickness and fragility. Clinically, we can see many kinds of posterior polar cataract. There are several different surgical techniques have been published, including gentle visco dissection without nuclear rotation and so on, for handling these difficult cataract cases. However, since most of the posterior polar cataract are acquired idiopathic posterior capsule malformation, can we manage posterior polar cataract surgery by ordinary procedures? I consider capsulasis is one of the key points in any kind of cataract surgery, especially in complicated cataract surgery. I always emphasize the pivot concept. We can, from this video, we can see obvious the differences between without pivot concept and with the pivot concept. No doubt, hydro procedure is the most important and dangerous step in such cases. Many surgeons consider hydrodissection in posterior polar cases always lead to PC rupture. Is that true? This is my ordinary hydrodissection procedure in ordinary cases by using a 27-gauge cannula. In order to perform a safe hydrodissection, I separate the hydrodissection procedure into 4 detailed steps. The first step, inject teeny quantity of BSS gently and continuously. In this case, we can see I only use 0.2 milliliter of BSS. The second step, let BSS free wave spread across the posterior capsule area. We can see the BSS free wave can spread across the posterior capsule area safely. Also spread across the posterior capsule area. The next step, BSS free-wave front should stop right on the opposite equator. We can see the BSS free-wave front stop right on the opposite equator. No more BSS injection. Also stop right on the opposite equator. Inject too much of BSS, resulting in the reflex back to the thinnest posterior pole area. Here, I consider this is the main reason causing PC rupture. The following step is the most important: decompress the BSS behind the equator. I use a 27 gauge cannula, touch the opposite nucleus gently to decompress the BSS behind the equator. Also decompress the BSS behind the equator from here. Rotate the nucleus or not is another controversial issue. However, I consider if we complete hydrodissection successfully, I would like to rotate the nucleus carefully. I also use a 27 gauge cannula, rotate the nucleus around an axis through its center gently and do not press the nucleus as possible. And we can see the nucleus can be rotated and separated from the posterior capsule safely. Let's link up the 4 detailed steps of hydrodissection in these posterior polar cataract surgeries. Even in a femtosecond laser aesthetic cataract surgery with so many air bubbles produced, I can carefully perform hydrodissection step by step and lens rotation smoothly and safely. Let's see another case also by using FRAC. We can see I can also perform hydrodissection and lens rotation very smoothly and safely. After careful divide the nucleus and nucleus fragmentation, we can see the posterior capsule was intact in all the cases. Then, after careful cortical aspiration and IOL implantation, we finish an eventful posterior polar cataract surgery smoothly and safely by using ordinary procedure. My conclusion, I approve posterior polar cataract is a posterior capsule malformation. We can use the same technique in our standard technique, our standard cataract surgery, as long as we follow the rule of 4 tips and hydrodissection, lens rotation, and perform every step carefully and precisely. The next topic is how to manage milky white cataract. In tumescent white cataract, are lenses so opaque in completely absent of the ray reflex. There are several types of mature white cataract. The challenge of removing mature white cataract, including absence of ray reflex, shadowing anterior chamber, and so on. The complications of the white cataract surgery, including capsular tearing during capsulasis, high rate of vitreous loss requiring vitrectomy, and so on. I suppose this is a nightmare to most of the young surgeons in white cataract surgery. So I recite some critical steps of white cataract surgery. The first step is anterior capsular staining. There are several materials for anterior capsular staining since 1993. Treatment blue is the most frequently used agent that with less toxicity to retina and endothelium cells. However, there are some side effects was published, including CME and TASS. There are 3 surgical techniques for staining the anterior capsule. The first technique is air bubble injection. This technique is very easy. However, time-consuming and difficult to reform the anterior chamber are criticized. The second technique is injection under viscoelastic agent. The advantages are the anterior chamber depth is well maintained, and the dye does not touch and damage the cornea endothelium. The third technique is intracameral one-step injection. This technique is faster and no additional instrument required, while endothelium damage is still a concern. After we know how to anterior capsular staining, does anterior capsular staining mean the whole thing to the surgery? Oh no, please remember, staining only enhances visualization. So the next critical step is OVD injection. Mature white cataract always raise intracapsular pressure. Uniform and overfilled OVD will help to flatten and the dome of the capsule to reduce the risk of capsular tearing. The next step is the most important and challenging capsulasis. The worst complication of capsulasis in white cataract surgery is escaping capsulasis resulting in capsular tear. We do need skilled at performing capsulasis in the regular cases before go on to white cataract cases. After we have accomplished the individual skill, we are going to perform capsulasis in white cataract surgery. Of course, capsulasis by femtosecond laser is the best way. However, not every patient can afford to use. After careful staining of the anterior capsule and OVD injection, we can perform the capsulasis under a better visualization. Many surgeons would like to use needle to aspirate out the liquefied cortical material before achieving capsulasis to release the intracapsular pressure and prevent unexpected radial tears. Capsulasis in white cataract by puncturasis with or without capsular staining to release the intracapsular pressure is published in recent years. Besides this method, how about performing capsulasis in white cataract by regular procedure without capsular staining? Without using anterior capsular staining, we shall slightly adjust the eye position to visualize better reflex of capsular flap. And each time the flap is released, remember to elevate the flap edge in order the flap is easier to grab again. After we have skillful technique and experience, let's try to perform capsule races in this free field, free white cataract without using anterior capsule staining by regular procedure. Grab. When we release the flap, remember to make a flap. Puncture and open the anterior capsule firmly and progressively, not too weak, to make a good flap in this intumescent white cataract and brunescent white cataract surgery by ordinary procedure. Under image-guided system can help us to perform a pretty good capsulations without staining the anterior capsule by the similar procedure and technique. Even in a small pupil, hard and mature white cataract, we can also perform a pretty good capsulations by using the same technique and procedure. In the past 2 years, I have performed 61 white intumescent cataract eyes. All capsulations procedures were performed successfully. No any capsular tearing was noted. So my conclusion, intumescent white and brunescent cataract is still a challenge. Cataract surgery requires skillful technique and experiences. Patients to perform every step to prevent unexpected result. And the last topic, I will introduce the Taiwan public insurance scheme for cataract surgery. In Taiwan, more than 99% population covered by national health insurance, and 93 hospitals and clinics join NHI. In 2017, Taiwan cataract CSR is around 8,500. Cataract procedure in Taiwan is reimbursed by case payment policy. Total case payment is only $600, including a spheric IOL. However, all other lenses need to extra pay by the patient, from $500 and $1,200 for a spheric IOL until more than $3,000. Femtosecond cataract surgery, patient need $2,500 extra pay. The Taiwan IOL market status now is around 66% reimbursed IOL. That means spherical IOL, not a spherical IOL. About my group, Taiwan Universal Eye Center. We have 20 eye centers and 50 eyeglasses stores in Taiwan and 8 eye centers in mainland China. This slide shows the number of cataract surgery from 2015 to 2017. We can see we are approaching 7,000 cases a year. we use the spherical IOL, we use Arcon and AMO sensor. A spherical IOL, we use Arcon, AMO, Rainer, Bochet-Long, Nidec, and Hoya XY1. Hoya Vivinus XY1 is one of my favorite and most used spherical IOL through a 1.8 to 2 millimeter clear cornea incision. Toric IOL, we use Arcon T3 to T9, AMO, Rainer, Bochet-Long, and VSY. Multifocal IOL, we use a lot multifocal IOL, including bifocal IOL, we use Arcon and AMO. Segmental IOL, we use MF15, MF20, and MF30. And EDOF, we use AMO, Symphony. Trifocal IOL, we use Fine Vision, Arcon, Panoptic, VSY, and Zeiss. Multifocal toric IOL, we use AMO, ZMT, ZXT, Arcon, ART, Fine Vision, Zeiss, and Oculentis. This slide shows the percentage of intraocular lens I performed. The spherical IOL in the Taiwan population is 66%, and in mine is only 29% spheric IOL, 33% aspheric IOL, and 7% toric intraocular lens, and and 31% premier presbyopic IOL. In the past 2 years, Oculentis is my favorite used multifocal IOL. About the femtosecond laser cataract, we can see in 2017, our group performed more than 1,000 cases, including almost 400 cases I performed. Additionally, this video shows my personal tips when I perform a complicated cataract surgery. And thank you for your attention.
Thank you. It's very interesting. For the sake of time, we have to move to